So, possible pain generator maybe in the disc, maybe in the facet joint, or say like sacroiliac joint, or some other area, maybe interspinous ligament. So in those, most of the procedures, we need this type of position when the patient is lying prone on a bed, and then this is I mean X-ray compatible bed. So otherwise, you will not be able to see anything under C-arm. So, and this is the C-arm. So this is the common position for most of the procedures. Now, before we go to the procedures part, let us talk about the C-arm first. So first you see that this C-arm has two parts mainly. So just think this part is the receiver. Okay, and this part is the emitter. So X-ray is coming from the emitter and X-ray beam is coming from the emitter, and it is received by the receiver. And then this is actually the C of the C-arm. And then there are multiple controls here. So controls part, I'm not going into it, but then just remember, and then this is the monitor. So this part we know, but then main important thing is that this is the emitter and this is the receiver. And see the previous picture. In the previous picture, so you can see that what is this part, which is we are seeing above the bed, patient bed. So this is the receiver. So most of the time, not most of the time, always the receiver is below the bed. Okay, and then between the operator and the receiver also there is a possibility to put the lead guard. There are different types of lead guards, so that the shielding can be done, so that from below the bed also the ray doesn't come to the operator. Okay, so here one important thing is that always the receiver is above the bed and emitter is below the bed. Okay, now always during the interventions we should save ourselves from the unnecessary exposure of radiation. So that is very important. So there are two organizations and they have made some recommendations. So one important recommendation is called ALARA principle. What we mean by ALARA? As low as reasonably achievable, as low as reasonably achievable. So this is this principle about the radiation. So I mean, we will do the all the interventions under X-ray, but we will see that radiation should not be too much. That should be very less. So there are three principles, three parts. Mainly, there are multiple other steps which you can do to decrease the radiation, but mainly three things. Always remember, that is time of X-ray exposure. If you are taking multiple exposures for a 15 minutes of procedure, you are taking 50 shots, 50 pictures of this C-arm, then total time is too much for one procedure of 15 minutes. So you reduce the number of procedures. Okay, number of shots, number of exposures you reduce. So one point is time, and second point which I always use, distance. Distance means if this is the some area, say this is the area of radiation, and you are standing here, and from the emitter your distance is 1 meter. Okay, and if at the just before the radiation, just before the exposure, you tell I mean, after putting the needle, if you just go there a bit at a distance, and you make the distance 2 meter, then remember the exposure is not only half, it becomes 1/4. Okay, so by decreasing the distance, you make the make the exposure to a greater extent, reduce the exposure to a much greater extent. Okay, so this one we always do whenever before exposure, we just go back one step or two step, and then we tell the technician to for a exposure, so that we get much less radiation. So these two things remember. And third thing is shielding. Like I am wearing a lead jacket. Okay, so this is one type of shielding. I can wear a thyroid guard also. I can wear a specific specialized specs. So those also I can use. There are multiple other types of shielding also. Shielding you can wear also, and you can use while during exposure, like say collimeter. Collimeter is a thing which reduces the aperture of the uh, exposure of the serum, which so it reduces the X-ray exposure. That is the thing. So that is collimeter. And there are many other shields are there, like gloves are also there. You can use that one also. So these three things are very basic things for doing all the X-ray guided procedures. You should remember that, because since X-ray is you cannot see, you may feel that okay, nothing is happening, everything is all right, but I mean, risk is there. So too much exposure, there is always a dose limit. We should not cross that dose limit. So dosimeter, we should use dosimeter. So two dosimeters actually we use. One is above the lead jacket, and one is below the lead jacket. I mean, over the skin. One is above the skin, or one is above the lead jacket. So these dosimeters also we should use. We should know that in 1 year how much exposure we are getting. So this is the first part. So just understand that we want to do all the procedures under X-ray, but not at the cost of our life. So we will reduce the dose of X-ray exposure dose, so that we do not get a side effect. That's it. Now let us talk about the for fluoroanatomy of lumbar spine. Let us see that how our lumbar spine vertebra looks like. So this I told. Any question?
So actually, sir, I just want to know any specification regarding the room where you'll place the C arm.
See, these specifications are not, what should I say, universally accepted or globally modified, nothing like that. So many states have made some specific rules, like our state has made at least 100 square meter should be the area of the room for a CRM use. Uh, but I don't know that this is not there in every state. It is there in our state only, so 100 square meter.
Anything about
Otherwise,
the wall thickness, sir? Wall thickness?
no. That is what I mean. Room size is not not fixed. Wall thickness is yes. Wall thickness or lead. If wall thickness probably 12 inch or something like that. 12-inch wall thickness should be there.
Okay.
Or if this much of wall thickness is not there, then you have to use the lead sheet. So I have used lead sheet actually.
Okay, sir. Okay, sir. Thank you.
Okay, yeah. So now comes, so this is the,
Am I audible?
yes, yeah,
Because I have done it later. So it is that if it is concrete, then it should be at least 5 centimeter, 5 inch. And if it is a brick, then it should be at least 10 inch. So that was the rule. And apart from that, if nothing is there, for the CM or removable device, the lead thickness minimal should be 1 millimeter. And if it is a fixed machine, X-ray, then it should be minimum 2 millimeter lead. Okay, that was the current guideline ARB.
Okay, sir.
yeah. Okay. So then comes, so this is the lumbar spine anatomy. So last day also I talked about this part, that we have 5 lumbar vertebrae, L1 to L5, and it is between the thoracic vertebra and sacrum. and then this is the biggest or largest vertebra in our body. So here the vertebral body is bigger. In cervical spine, body is smaller. So there are some differences between cervical spine, thoracic spine, lumbar spine. Everything has some, every spine has some characteristics. So lumbar spine, here the body is the biggest and it is very thick, and it actually it transmits the main weight of our body. Okay. So here I can see from above that this part. Okay, so this is the vertebral body, and I'm seeing from above. So here, this part is lamina. Okay, these two are lamina. This part is spinous process. This part is spinous process, and here these are transverse processes. These are transverse processes. Here, the facet joint, we are not seeing it very nicely. So in this area is the facet joint area. So here I can see this one, this part, which we are seeing in this picture. This we are seeing from above. So here, how the facet joint is formed. So facet joint is formed by two articular processes. So here there is one articular process. So this articular process is called superior articular process, which is a part of the lower vertebra. So this is the lower vertebra. So it is the part of the lower vertebra. And from upper side, there is another articular process. So this articular process is formed by the upper vertebra. Okay. So they are making one facet joint from the, so this is called inferior articular process. Upper one is IAP, inferior articular process, and lower one is the SAP. Okay, superior articular process. So the lower one is always lateral and IAP is always medial. So this one, and now I am showing you the X-ray. So this is the AP view. Always when we are seeing the X-ray, patient is coming to us with an X-ray, we are mainly seeing the AP and lateral view. Just by seeing the AP and lateral view, we should be able to understand that which structure is what, because we should be able to understand that which structure is what, because we are seeing a three-dimensional structure in a two-dimensional way. So I'm just asking you, I think you all know it, but still, so what is this structure? This area. Anyone?
Facet.
No, specific.
Inferior articular process.
Inferior articular
Process.
Yes,
Inferior,
this is
superior,
IAP.
inferior article.
Yes, this is IAP. So you can understand that this part is SAP. This part is SAP. Okay, this part is SAP. Okay, so this is one important thing. Second thing is, like say, can you understand what is this? What are these things? So these are
Spinal
Disc,
canal.
no.
disc,
See carefully. Two lines are there. These two lines here also two lines of plate-like. These are plate-like. So what
end
are these
plates,
things? These are end
end
plates. This is nothing but this one. So here we are seeing from above. So this one. So these end plate only. If I see from one side, here it is one line I am seeing. If I see in an oblique way, then I may see in a two lines like this. Okay. So these are the inferior one end plate, vertebral end plate, either inferior or superior, doesn't matter. It can be two lines anywhere. So this is the end plate. This is end plate. This is end plate. Okay. And then we can understand that this one is your. This one I think everyone can understand. This one
transverse process,
transverse process. This one is transverse process. Okay. This one. These round things. What are these things?
pedicle,
Pedicle. So this is the most important thing, because in a osteoporotic spine also you have to first search the pedicle. Okay, so these are pedicle and these are spinous processes. These are spinous processes. And what is this area, this black
Foramen.
area?
Yes, sir.
This is spinal canal. This is spinal
Okay.
canal. Okay. This is spinal canal in between. Just we are seeing between the lamina. Through the lamina, we are seeing the spinal canal. Okay. And here, if I tell you that what is this area? What is this area? What is this area? Though it is in AP view, we are not seeing very nicely, but still.
Foramen.
Yes. This
Foramen.
is intervertebral foramen. This is intervertebral foramen. So this part, oh, anyway. So this part we are seeing when we are seeing in AP view. So we are seeing from anterior posterior side. So this part we are seeing. Okay. So this part we were. So we were seeing this part. Okay. Anyway, so next is lateral view. So here we can see which structures are not easily visible in AP view. So there are two structures.
Foramen.
No, foramen is one structure and another structure is pedicle.
Pedicle.
Though we can see the round structure in pedicle AP view, but that is a end-on view. We are seeing straight 90 degree. That's why end-on view. And this is the pedicle from the side view. So this is the pedicle. Okay. So we can see that whether the pedicle looks normal or not, or there is a fracture or anything like that. And two other structure which cannot be seen in this view. So one structure is your transverse process. This is the transverse process. So these transverse processes we are seeing end on. That's why we are not seeing. So this is one important thing. And second thing is lamina. Lamina also we are not seeing clearly. Okay. Lamina is also end on. So we are not seeing. So lamina and transverse process we are not seeing. Here the facet joint. One important thing is this is the facet joint. Okay. Remember this facet joint area means this is SAP. This is SAP. This is SAP. This is SAP. In normal person, this part is not that clear. But remember the facet joint level is at the level of the disc. So sometimes when it is not clear also, we have to understand that which structure is where and our needle is going up to how much distance. Then we can we remember these facts so that we can identify the areas. So at the level of the disc, if you go like this, you will get the facet joint mainly. At the level of the disc, you will get the facet joint. At the level of the disc, you will get the facet joint. Okay. So this is and this part is SAP. So it looks like a bit anterior. So this is SAP and this is the IAP, SAP. Okay. So this is the lateral view. So the last day I told you that we will see the curvature also, that how it looks. Now AP and lateral view we understood. Now for intervention we are using always a third view. What is that third view? That is called Scotty dog view. So Scotty dog view means that is a oblique view. So this is the oblique view. Remember, if the procedure is in the right side, we will do a oblique. We will see the oblique view in the right side. Or if the procedure is in the left side, we will do oblique in the left side. So we will see the Scotty dog in the left side. Demonstrate it, but still. So this is the oblique view. So here, important thing is where is the dog? So try to match with this dog here over the picture, this picture. Okay. So how we will match it? So here I am making one dog. I am making the front side of the dog. The back side is not needed. Okay. So you can understand that which part is what. So here this the middle part, these are the pedicle. Pedicle is eye of the dog. Pedicle is eye of the dog. Okay. Then this nose part. So nose part is what? Nose part is transverse process. Then comes a neck. So what is this neck? This neck, it looks like if there is a black line or a fracture on the neck, then it is called that there is a tie in the neck. Okay, so this neck is pars intraarticularis. Pars intraarticularis. Sometimes, in a case of listhesis, you may see fracture in this pars intraarticularis. What is the terminology we use for pars intraarticularis fracture?
Spondylolisthesis.
Last day I told you.
Spondylolisthesis.
Spondylolysis. Pars intraarticularis fracture is spondylolysis. Listhesis is slippage of vertebra. It is different thing that listhesis and lysis many a times they are associated. I mean, we can see together, but the meaning, fracture means lysis. So this is spondylolysis. Okay. Then comes this part is lamina, this part is lamina, then this part is lamina, and below we can see the front leg means IAP. Front leg means IAP. So what is the SAP? SAP is the ear of the dog. SAP is the ear of the dog. Okay. So this whenever we are seeing the X-ray, right side is right side and left side is left side. I mean, left side of the patient is left side on the monitor. Right side of the patient is right side on the monitor. We fix it like that. Of course, we can do the opposite also, but that is not done usually. So here we are seeing the dog's mouth or nose on the left side. That means this patient has problem on his left side. We are doing a procedure on the left side. Okay. So now this is a Scotty dog on the right side. We are seeing this dog in the right side. I think you all can see this dog again, isn't it? So here it is the dog, here it is the dog, here it is the dog. Okay, so you can see all the areas. So nose of the dog, ear of the dog, eye of the dog, front leg of the dog. So these are the most important parts of the Scotty dog, and mainly this is for the identification of the parts. These pictures are taken on very good spine, but if when a patient comes to you, this type of good picture you will not get. So in that case, you have to understand or identify the structures. So this is the front side. Now the opposite side is not important, but then just to remember that hind leg means this area. So this area is the IAP of the opposite side. This is the hind. Just a minute. Okay, so here. So where is the hind leg? Hind leg is here. Hind leg is here. Hind leg is here. Here. So this hind leg means this is the IAP of the opposite sides. We do not do any procedure in the opposite side, but this is just for remembering. And the tail is the SAP. Tail is the SAP. So this is the tail of the tail is the SAP. So this is the opposite side. So it is not needed, but still. Okay, so now while doing the procedure, there are 5 steps. Just remember, first is site determination. So site determination means I will see. Any question? No. So okay, site determination means patient's right side, our screen's right side. That should be that is the first step. First you check that. Second is level identification. Level identification means we will see that which level is what. if our target is L5, so which one is L5, or it is L4, so which one is L4, it is right side or left side, those things we will check. Our I mean area of interest, we will check the area of interest. Now comes the third step. So third step is actually the making the oblique view or the Scotty dog view. Okay, but this Scotty dog, making the Scotty dog view has two steps. So one is true AP view. True AP view, how it is done? So pedicle to spinous process distance should be equal in both the sides. This part I will demonstrate. And then end plate parallel. So end plate should be parallel. So these two things I will demonstrate, and then that is called true AP view, and then we will go for oblique view. So this total thing, first true AP view, then oblique view, will make the Scotty dog view. Okay, so Scotty dog view is most important for starting all the procedures. So here just these 5 steps total, 1 2 3 4 5. So you just remember this thing, this will be required. Okay. Okay, I will show this part first, then we will proceed a bit more. Okay, in between, if you have any question, please tell me.
Sir,
Yeah,
oblique view, how much degrees you angle?
this one I'm just telling you. Okay, just a minute, I'm just okay. Oh, so I think you all can see the picture, isn't it?
Visible, sir.
Yes, sir.
Oh. So this is the picture is visible. So now 5 steps. First 5 steps for a Scotty dog view. So here this is the mannequin. Okay, this is the mannequin, and you can see the C-arm here. I'm just okay. Okay, so this is the mannequin. So this is the head side. This is the head, and this is the hip side. Caudal side is this side. This side is cranial side. This side right side. This side left side. So this say think one person is lying prone. Okay, so this is the receiver, and below the bed, that is the emitter. So so this is the commonest positions. Now I will show the first five steps for a Scotty dog view. Okay, so first shoot on AP view. Okay, so here first thing what I should see, that right side is right side or not. So patient's right, this is the patient's right. So I will just hold the forceps on the patient's right, and let me check whether it is the screen's right side of the screen or not. So right side of the screen and right side of the patient is matching. So first step is done. Second step is, say I want to do a procedure in the L4 L4-5 foramen level in the right side. So right side L4-5 foramen level. So what I have to do, I have to check that which one is L4 or L5. So there are two procedures, two ways to understand. One thing is I will see from below. So which one is see from below? So here you can see that I can see the iliac crest. So where is the iliac crest? Just a minute. So here, okay, shoot. So I want to check the L4-5. So here I can see the right side of L45 is my target. So here it is the iliac crest. It is the iliac crest. So at the level of the iliac crest, we know it is between L45 or the lower part of the L4, but it is never on the L5. It is either L45 space or this is the lower part of the L4. So we can understand clearly when we are seeing the iliac crest that this is L4 and this is L5. We can go up also to see that whether we are correct or not by seeing the 12th rib. So here first I am doing one thing. Should oh. So the tip I am keeping on L3. So this is the tip I am keeping on L3, and let's go up to check that whether it is really L3 or not. Okay. So this tip was on the L3 and this is L2, this is L1 and this is T12. We can see that 12th last rib is there. Okay, so we can start from upper part also, from the last rib also we can count from the iliac crest also, but it is always better to count by the iliac crest because that is more constant, or you will not miss anything, because from upper part someone may have an extra rib, someone may not have the 12th rib normally. So in this way, so we count from the iliac crest mainly. Okay. So this is the second step we understood. Now I am going on the L4. So this is the L4. So L4 right side is my target. Okay. So second step is done. Now comes the third step. So third step is true AP view. So what is true AP view? So for true AP view, I have to see. So what is meant by true AP view actually? True AP view is meaning is, see, this is a spine. This is a spine. But true AP view, I may not be able to, and so I am showing you. Just a minute. Okay. So what when we are saying it is true AP view. So as I told you that it has two steps: pedicle spinous process distance and end plate parallel. Okay. So what I mean by true AP view? So true AP view meaning, here in this picture you will understand that I want to see this structure. So say I am now seeing the lumbar spine here in this area, but I want to see the lumbar spine, the specific spine, not the L1 to L5, say L4 I want to see in a straight 90-degree angulation, just from above, from the 90-degree angulation, or say I want to see the L5 at the 90-degree angulation. In both the cases, my angulation of the C-arm beam or X-ray beam will not be same. Why? Because there is a normal curvature of lordosis. If this is the lordosis, normal lordosis, and say this is L5 vertebra, this is L4 vertebra, this is L3 vertebra, like that, or L2 vertebra. So this is I mean, my picture is not good at all, but still, so say this is L2 and this is L5. And now if I want to see this vertebra, L5 vertebra, in a 90-degree fashion, then my X-ray beam should come like this, in this direction, or say just the opposite, this direction. Okay, this direction, but it should be 90-degree with this end plate, or this vertebral body. Okay, so here it should be 90-degree. Then only I can see it in a, or say I'm showing you. So two vertebra, I'm just making it. One is like this and one is
Your
like
voice
this.
is breaking.
Voice is breaking. Anyone else? My voice is breaking.
No, it is absolutely all right. Probably an internet connectivity problem.
Okay, internet connectivity maybe. So see, here in say in L5, if I want to, or it is L1. So if I want to see the L5 in a 90-degree, then X-ray beam should be going like this directly. But in the same direction, if it goes over the L1, I will not see it in a 90-degree fashion. So here it should go in this way, okay, so that it makes a directly it remains in a 90-degree fashion like this. If this is the end plate, then this end plate direction and this X-ray beam direction is just parallel. And here, if this is the end plate, so this end plate and this beam direction is just parallel. So making, if this is one type of angulation, so this is another type of angulation. Okay, here in this picture also you see said that this is one type of angulation, this is another type of angulation, and this is another type of angulation. So for that reason, since we are seeing different areas, that's why this angulation has to be made. Mainly true epiview means when we are seeing directly to that specific vertebra at 90-degree, then only we can call that we are seeing a true epiview. Okay, so try to understand this concept, because otherwise you will not be able to understand the picture. Okay, now I show you. So here what is happening, and now I want to see the L4 vertebra in a true epiview picture. Okay, so the third step, what will happen? So first thing, the vertebra, I don't know, they say this is the skin, so this is the skin and vertebra inside. I don't know whether it is like a square, it is seeing like this, or it is seeing like this, or it is seeing like this. I don't know that. So that's why now what I mean, for seeing true epiview, I have to be totally 90-degree. So what I will do, first step is the spinous process and pedicle distance should be equal, so that vertebra is not rotated like this. Vertebra is first, it is straight. We have to do so. We should so here see one thing, that in L4 vertebra, say this is L. So this is fourth vertebra. It looks like it is a bit smaller. This is the spinous process and this is the pedicle. This side it looks a bit bigger, isn't it? So this is L4, but this looks a bit bigger and looks a bit smaller. So this is not true epiview. So I will make this part a bit bigger. How can we make this part a bit bigger? This is right side. So I will tell him to make a bit right oblique. Yes, so you can see a bit right oblique it has been made. Now so now it looks more I mean equal distance from the spinous process to pedicle. Distance looks more equal. So this is the first step of true epiview. So what I have done, why it was not same, because the vertebra inside was not straightly placed, it was a bit rotated. Okay, so someone can have kyphosis, someone can have scoliosis. So it is more of a scoliotic type of vertebra under the skin. Under the here, of course, it is manicuine, but under the skin it was a bit scoliotic. That's why I had to do a bit oblique towards the right side, so that this lamina becomes a bit bigger and I can see the spinous process and pedicle distance equally. Okay, so this is the first step. Now comes second step. So what is the second step? Seeing the end plate in as a single line. So which is the end plate? So this one is the end plate, two lines. Here single line. So we are seeing in this view, we are seeing these vertebra in a straight way, in a straight 90-degree. But we are not interested in this L3 vertebra. We are interested in L4. So we have to make these two lines as a single line, as a fourth step. So what I will do, I will make it a cranial angulation towards the head, So as soon as I made the cranial angulation, this has become one line. Okay, so this is the fourth step. See, earlier it was one line, now it is two lines. Okay, so that means with this angulation, I am seeing this L4 vertebra in a 90-degree fashion, but not the L3 vertebra. In L3 vertebra, it is now, we are not seeing in a 90-degree fashion. So, okay, so this is the two steps. One is spinous process to pedicle distance should be equal, and second is the end plate, where you are interested at that point should become one. Okay, so remember, you cannot make everything you cannot see at every point in a 90-degree at the same time. So you just have to see either this end plate or this end plate or this end plate, whichever you are interested. So at present, I am interested here because I was interested in the right L45 foramen area. So this is the right 4-5 foramen area, and I was interested here on this end plate. So this is the fourth step. Now come fifth step. So as I am interested in the right side, so I will tell him to make oblique in the right side. So how much oblique? So this was the question. How much oblique? Okay, shoot. So it is not hard and fast. See, here also you are seeing the Scotty dog very nicely. So this is the Scotty dog. So this is the Scotty dog. This is the Scotty dog. So this is the Scotty dog. So as soon as you make it oblique, you start seeing the Scotty dog. But for procedure, we maintain, for different procedure, we make different amount of obliquity we maintain. It is nothing fixed, because as I told you, someone may have kyphosis, someone may have scoliosis. Every human skeleton is different. So it is not fixed. Your structure should be evident, clearly seen. Then it is patient to patient basis. You are seeing the structure clearly, then it's okay. So here I was interested in L4-5 level, that means this level in the right side. So now two things in obliquity. How much oblique I will do? I will make this facet joint come in the middle part of this vertebral and end plate. So where is the end plate distance? So from this part to this part, and this is the middle part. So I will make this facet joint to come up to this much. So he will make a bit more oblique. But that's it. So this is the so this much is okay. So I can see the Scotty dog view in all the levels. Okay, clearly you can see the Scotty dog view. I think everyone can see, isn't it?
Yes, sir.
Okay. So
Yes, sir. It's visible.
what is this?
SIP. Superior articular process.
Yes, SAP. Okay, okay. So I think you all can see. And what is this?
Inferior articular process.
Inferior articular process. So this is the most important thing. And this area, what should I say? This area?
Foramen.
Foramen. Yes, intervertebral foramen. So, okay. So this is the first step. So getting a this one Scotty dog view is the first step and most important step for all the procedures. Okay. So just 1-2 more things, and then Dr. Devjyoti will take other part of the class. So okay, so these 5 steps I have shown you, and then So just here, concept is most important. What I am trying to do, that is most important. Okay, I want to see the vertebra inside the skin in a 90-degree angle, in a straight over the vertebra. So I have to compensate for the kyphosis or scoliosis, lateral bending, anything is there, I have to compensate for that with X-ray from outside. That is the main thing. Here, tunnel view. What is tunnel view? What is so few important things for intervention? Tunnel view, needle tip bending, and C-arm angulation and effect that I will tell you. So tunnel view is, this is called tunnel view. When we put a needle in the under the X-ray and X-ray beam, and we are seeing the whole needle like a point. So this is called tunnel view. We are seeing the needle like a point. But so here you can see in lateral view, the needle is this long needle, but in a oblique view, when I'm seeing just over the needle hub, so it is like a point. So this is called tunnel view. So end plate parallel. Okay. So here the sympathetic. Okay, this part I did not show you. And another thing is needle tip bending. So this I will show you while doing the procedures. In most of the procedures, we sometimes bend the, we always bend the needle tip. Why do we bend it? Because if you bend the needle and you put a pressure on the hub, then also the needle will not go straight. It will go to the during I mean towards the direction of the angle. Okay, so the usefulness of this bending is that when you want to change the direction of the needle inside the body, you don't have to come out. You just rotate the needle hub. You just rotate the hub, and direction of the needle can be changed from outside, and you don't have to come out and redirect the needle. That is not needed. So that's why bending is done. Okay. So this part, please keep muted. Someone's child is okay. So so this part already I told you, this part, that for different area, different vertebra, C-arm angulation has to be different. Sometimes the receiver is cranially tilted, sometimes caudally tilted. Another thing, when the receiver is cranially tilted, actual name is codocranial angulation, because the emitter becomes caudal and receiver goes cranial. So from emitter to receiver, the X-ray beam goes, and it is called codocranial angulation. But for easy direction to the X-ray technician, we say just make cranial angulation. So I have seen many places also people are seeing cranial angulation, but it is actually codocranial angulation. Okay. So here, in this Coti dog, there are multiple interventions are done. Sympathetic block is done. Disc access, for disc access also is done when we see the Scotty dog view. Then jet joint block or facet joint block is done, or medial branch block of facet joint, that is also done, or transforaminal epidural is also done. So most of the lumbar spine procedures is done in this view only. Okay. Now, okay, this part is Dr. Devjyoti will take concept of diagnostic evaluation. Okay, then. Yeah.
Audible?
Yes, yes.
Okay. So let me start. Why pain management is different from any other subject? The basic lies in the diagnostic intervention. Because if you look at all other branches managing pain, whether it's orthopedics or neurosurgery or it's a rheumatology, so all have one limitation. That is, there are possibilities when the pain generator is not properly identified. So in the last classes, you have already understood we have this new armamentum by which actually we can find out which structure is causing pain. So here I'll be discussing for the low back, what are the diagnostic interventions commonly performed and what is the principle behind it. Definitely the details of each intervention will be discussing afterwards in next classes, but it's a general class on the diagnostic intervention for the low back pain. So let's share the presentation. I think my screen is visible to everyone. Is it visible?
Yes, sir.
So why we do diagnostic intervention? First of all, to identify the source of pain. Remember, there are structures which can cause pain, for example, disc or facet joint or the nerve root. But sometimes it's very difficult in a back pain setting that which structure is the main culprit. You have to find out when becomes very difficult, especially in the degenerative spine, because what happens in aged patients, sometimes there are problems, but these problems do not correlate with the pain. So if you see a disc bulge, but you don't see the other problems or other sources, sometimes a simple myofascial pain can be radiating or referred to the lower extremity, and there could be a possibility of mistreatment. For example, for a myofascial pain, a discectomy was done. So these are not the isolated incident. Even for the sacroiliac joint pain, the discectomy is done. This type of treatment happens. So here the most important thing is by doing a diagnostic block, you perfectly identify the source of pain. And the second point is related. So avoid unnecessary treatments, including ineffective surgeries, therapies, or medications. So what happens if you are having a sacroiliitis and the pain is coming from the sacroiliac joint? It might not always happen that every time it was seen beautifully white in the MRI, but sometimes it happens in chronic sacroiliitis that these bony changes remains. Sometimes they could be picked up by the imaging investigations, but not always matching with the pain. So here by diagnostic block, we can actually match with the pain. So basically all our imaging is basically an objective identification of the problems, but pain is subjective. So here it is a bridge between these two worlds. So whatever we are seeing as an object, the lower back, and how is the pain. So diagnostic block helps to bridge those gaps. Next, coming to the confirmation of diagnosis. So if you are suspecting a facet joint to be painful, you put a local anesthetic, you are sure that this facet joint is the painful. So it is the confirmation. And it helps in the therapeutic intervention as well. For example, if you are doing a median branch block and then you are finding there is a good pain relief, then you can go for the radiofrequency ablation, which is a therapeutic procedure and by which you can treat the condition for a long term, as well as it helps to prevent the chronic back pain, as well as remember, if the patient is suffering from back pain, the degeneration increases because lack of pain, lack of movement, lack of blood flow, lack of nutrition, lack of calcification. So ultimately, eventually, it results in a vicious cycle and ultimately more degeneration and more chronicity of the pain, which can be prevented by the diagnostic block and the adequate treatment of the condition. So, which is the culprit? This is my question for the diagnostic block. Diagnostic block helps to find out what is the culprit. So, what are the procedures to find out then? For example, the simple procedures like the diagnostic intra-articular facet joint block. But what is done? You are putting local anesthetic within the facet joint intra-articularly and check whether the pain relief is there or not. Similarly, we have the diagnostic medial branch block for the facet joint, where we are putting local anesthetic 0.5 cc that goes within the medial branch and close to the medial branch, which is supplying the facet joint. So what happens when we are satisfied that after blocking this to medial branch, this pain is gone? That means when we'll be doing a radiofrequency of this, the pain relief will be there. Provocative discography is the condition that is used for the discogenic low back pain. So we all know, I discussed previously in the last classes, what is discogenic low back pain. So basically in discogenic low back pain, the the outer portion, that is the annulus fibrosus of the disc, is not pain sensitive except for the outer one third. But what happens due to degeneration? There are free nerve endings that go inside along with the angiogenesis, and that becomes the receiver of the pain. So whenever there is increase in pressure, that causes pain. But to prove that this is the cause of the pain, because in many of number of the times, the signs, for example, a hyperintense zone or a gas shadow, or sometimes we call it the modic type 2 change, they are not present every time in the MRI. So even in those cases also, we can actually go and we can gradually, artificially increase the pressure of the disc. And this condition is known as a provocative discography, whereby increasing the pressure, we can reproduce the concordant pain. Concordant pain means the pain for which the patient came to us. That is the primary pain. And when we artificially can reproduce that pain by increasing the interdiscal pressure, then we assure that this disc is the painful disc. And remember, in this situation, usually we do another thing. We, instead of going only to one disc and increasing the interdiscal pressure, we go one level up and one level below as well whenever possible. And in those conditions, we compare with the other discs. So basically, it's a comparative analysis, because remember, there are a number of factors that can increase or decrease the pain for one patient. But if you are matching with the same patient for the another disc or normal disc, then you are 100% sure that this is the source of the pain. That is why we can find out the disc as a source of the pain when there is no disc herniation or no major disc prolapse. Then comes the sacroiliac joint pain. So sacroiliac joint block is used for the sacroiliac joint pain. So it is basically an inflammation of the sacroiliac joint, which could be traumatic, which could be degenerative, which could be inflammatory. So there are multiple reasons for the sacroiliac joint pain. But when there is sacroiliac pain, we can easily go inside the sacroiliac joint. We can put local anesthetic and ask the patient whether you are still having the pain or not. If the pain goes, then definitely it is the sacroiliac joint which is the source of the pain. Similarly, comes to the piriformis muscle. When the piriformis is having myofascial pain, it is compressing and irritating the sciatic nerve. It can cause a sciatica-like situation, which is known as a pseudosciatica. And in those conditions, when we go just over the piriformis muscle and inject small amount of local anesthetic within the piriformis, and that gives the relief of the pain, we can call it a piriformis syndrome. Similarly, in the situations when there is repeated inflammatory radiculitis, or sometimes there is a post-operative situation, when there is an epidural filling defect, we can find out with the diagnostic procedure, which is known as the epidurogram. In simple words, you all know about myelogram. What is done in myelogram is basically going to the intrathecal space, then injecting the dye and taking the photograph. That is a myelogram that was used previously when MRI was not there. Even for a disc prolapse, previously myelogram was used to detect the disc prolapse. But nowadays, after MRI, the use of myelogram is reduced, but similar thing can happen in the epidural space as well. So what can happen after operation in case of situation of the post-laminectomy, or sometimes in case of feedback surgery syndrome, there is the same similar name actually. So when we are putting dye in it, we can find out a filling defect in the epidural space that can actually indicate there is could be an epidural adhesion. Remember, even after any surgery, there is always a fibrosis. So here also after the back surgery, there is a chance of the fibrosis, especially at the epidural space. They are joined and they are sticking to one another, that can give rise to pain, and which is known as the pain because of the adhesions, and for which we do a diagnostic procedure which is known as the epidurography and epidurogram. And for the treatment, we can go for the adhesionolysis with the help of the Rax catheter or with the help of the epiduroscope, whatever might be. But remember, this procedure is not a very successful procedure. That's why not commonly done today. But yes, that gives us a clue for which the pain is happening. So in most of the cases, we might have to go either for the epidurogram or the spinal endoscopy. Similarly, if you are suspecting a pain which is actually from a sympathetic origin, for example, a pain due to CRPS or a pain due to a Barrett's disease. So in this condition, remember, Barrett's disease is not a sympathetically mediated pain, but there are two type of indications for which we actually go for the sympathetic nerve block. One is the sympathetically mediated and sympathetically maintained pain. For example, complex regional pain syndrome is one type of sympathetically mediated as well as maintained pain. And sometimes it can happen that in cases where there is a vaso-occlusive disorder. For example, it could be a Barrett's disease, it could be renal phenomena, it could be a frostbite. So in those conditions also, we can block the sympathetic nerve to increase the blood flow in the affected limb, by which actually we can help the patient to relieve the pain, as well as we have seen even in case of gangrene due to vascular occlusions, if we are able to perform twice or thrice, we can be able to prevent the gangrene as well, and we can get back the limb as well. So it's very important. It is difficult. Sometimes it is not very predictable, but sometimes it can be done repeatedly, but the results sometimes are very astonishing, basically. And definitely for the myofascial trigger point, we have the trigger point injection. So these are the overall diagnostic low back procedures that we perform in different settings and different conditions. So I think I've understood the role of the diagnostic interventional pain management procedures. So what is diagnostic facet joint block? The simple is that when we are suspecting the facet as a source of the pain, to confirm the facet joint as a source of the chronic low back pain, we do a diagnostic facet joint block. So what is done? Basically, intra-articular injection is very simple. Go under the fluoroscopy, check, find out which level you are suspecting, go within the joint. That is a technique, that is a complex technique that I will show in the next class. So after going there, inject small volume, and it is a standardized volume 0.5 cc of local anesthetic, usually 1% lignocaine within that joint. And if there is a pain relief, then the source of the torture pain is this. It could be arthritic pain because of the degeneration. It could be because of the spondyloarthropathy or ankylosing spondylitis. So that can happen. There could be multiple causes of that. But ultimately, facet joint is the direct source of the pain that we can identify, and based on the condition. For example, if the patient is having a spondyloarthropathy or an ankylosing spondylitis and the patient is having facet pain, then definitely for a temporary measure, we can go for the intra-articular injection for relieving the pain. But if for the long term, we have to go for the exercises as well as for the DMARDs. And in this non-responsive cases, we can go for the radiofrequency ablation as well. Definitely for a degenerative cause or a cause where there is any problem in the leg for which there is an imbalance in the facet joint pain happened, in those cases also we can go for the radiofrequency ablation and get a long-term relief. So that is the importance of the diagnostic facet joint block. But remember, there is a question which is good. Either go inside the joint, that's the intra-articular injection, or go to the medial branches. So there are definitely some plus minus in both the cases. Remember, one facet joint is supplied by the two nerves. So one nerve is coming from above, one nerve is coming from below. So for example, if this is a L4-5 facet joint, definitely this is the L4 root. So here the nerve which is coming from below is basically the L4, and the nerve is coming from above is the L3. So remember, L4-5 facet joint is supplied by the L3 and L4 level median branches, whereas the L3-4 facet joint is supplied by the L2 and L3 level median branches. So whatever the number is, it's not very important. But what is important is that there is a consistent position for these median branches, and that goes at the junction of the superior articular process and the transverse process. So here it is the superior articular process, it is the transverse process. So in case of a suspected facet, we have to go one level above over the, this is the ear of the scotidog, this is the mouth of the scotidog, between the ear and mouth. So you have to go into the angle. Here also you have to go to the angle. And after going there, you have to stimulate to find out whether you are able to stimulate the medial branch or not. And medial branch, as we know, it is supplying one muscle as well, that is known as the multifidus. So once we see the multifidus contraction, then we are sure that it is the medial branch which is getting stimulated. But for example, instead of going here, okay, at the medial branch, if you go here, what will happen? If you go to the main nerve root and do a motor stimulation with the 2 hertz and 2 volt. So what could be happening? Can anyone tell?
Weakness.
No. For the stimulation, there will not be weakness. But what will happen? If you do the radiofrequency ablation, definitely there will be leg weakness. But what will happen if you stimulate here? The musculature of the legs will be stimulating. And depending on which route you are stimulating, the area or the muscle supply will be based on that. So for example, if you will be stimulating the S1, it will be stimulating thigh back muscles and going up to the great toe. So these are the muscles supplied by those nerve nodes, they will be actually stimulated. So that will happen for the L5 as well. So here we have to reposition and ultimately we have to go to this area. So after proper sensory and motor stimulation, we have to block this nerve. So before doing any such procedure, for any ablative procedure, it is very important to go for the both sensory and motor stimulation. Check you are at the right place, you are not burning any nerve which is unintentional, and then you can actually give the local anesthetic to numb that nerve and then go for the radiofrequency ablation. So there is a question, which type of diagnostic block will be better, whether it's the median branch block or the intra-articular block. So there are both advantages and disadvantages of those. Let us come to one by one. Median branch, what is the advantage? First of all, they are superficial, they are easy to perform. You don't have to go inside the joint, so it is very easy to perform. But the problem is the prognostic value is there in the subsequent denervation. So there are two advantages. One, easy to perform. One is that prognostic value for the subsequent denervation, because what is happening in the intra-articular injection you are giving, where ultimately we are have to do a medial branch block, because for the long-term pain relief, for the short and intermediate term, you can go for a steroid injection within the joint that will reduce the inflammation. But in a chronic pain, in the long-term situation, ultimately, even after diagnosis by the intra-articular injection, you have to go and then you have to block the medial branches to check whether the pain is relieving or not. So it is comparatively easy to perform, and prognostic value is there for the subsequent innervation. So that is the advantage. But disadvantage is, for one level you have to put 2 needles, for 2 levels subsequent you have to put 3 needles, and 2 needles distal. Okay, for example, if the L45 and L12 is involved, then you have to put 4 needles. So basically you have to inject more needles to the patient. So that's the disadvantage. And sometimes what might happen, remember, if we say that 0.5 ml is the ideal, but it might happen in certain situations if the 0.5 ml of local anesthetic, instead of remaining only to the medial branch, I might go into the lateral and intermediate branch. We all know there are 3 branches from the dorsal rami. One is the lateral branch, which supplies the skin, subcutaneous tissue, and some muscles as well. Whereas the intermediate branch supplies the longissimus muscle. The medial branch supplies the facet joints as well as the multifidus muscle. So what will happen? The pain coming from the longissimus or the pain coming from the skin, that can also be blocked if you are giving more volume, or sometimes it spill over to that. So the diagnostic efficacy might be lost. So that is the problem in case of medial branch block. Whereas intra-articular also having some advantages, also disadvantages. Definitely it is more accurate, it is single prick. So they are the advantages. But disadvantages, it is comparatively difficult to perform. There are chances of rupture of the capsule if you are injecting too much and pushing too much pressure. And there are chances that in case accidentally you can go through and through. Remember, it is not easy to go through and through, because in normal condition there is a curvature within the facet joint, so you cannot. But in certain situations, the patient's spine is not proper, there is a space adequate, then you can accidentally go into the epidural and subarachnoid state accidentally, and then all the diagnostic efficacy is lost. And if you give too much volume, then ultimately there will be anesthesia in the legs. So that we do not want. And it doesn't happen commonly, but definitely you have to know, you have to be careful, you have to be wearing the joint. But coming to the provocative discography. So I have told the provocative discography is the only way by which we can actually prove the intact outer side. Even with the intact outer side of the disc is the source of the pain. So that could be another possibility. So in provocative discography is to identify the painful intravertebral discs as a source of the back pain. Procedure is commonly done with a contrast injected within the disc, which produces the pain to confirm the disc as the pain of the source of the pain. Now, indications include the chronic back pain with unclear diagnosis, and we are planning for the interventions, and we are suspecting a case which is because of the discogenic pain or internal disc disruption. So what is done? Here we compare, I have told you 3 needles is required. We compare with the normal disc, with the effective disc, with the 2-level disc, 1 level above and below. And there are 2 steps of it. One is the provocative part, in which we actually increase the pressure and ask the patient whether the pain is there or not. And then there is a part which is known as the post-discogram CT scan. Then we check the dye within the disc, how it is going, whether it is into only inside the nucleus pulposus area or not, or whether it is going outside and going into the annulus or not. Okay, so these are the things but there are multiple challenges. For example, the patients are having different pain sensitivity. Some patients may be more sensitive to interdiscal pressure increase, some patients may be less sensitive. Then there is a chance of placebo effect, that the doctor is doing something, so I am going to get a relief. So that can also happen. Then you have to fix the other parameters, then gradual and controlled increase in patient is required. That is why we actually compare with the same patients 2-3 discs. Okay, so 3 parameters are here noted. One is the opening patient at which the fluid starts flowing inside the disc. Then the maximum pressure at which we are able to reach. Usually, it is the pressure at which we are getting more than 6/10 intensity of pain. We ask the patient, we make the patient understand about the numerical analog scale, and then we inject it. And we take the difference of this maximum pressure and opening pressure, and the pressure that comes as a pain generating pressure, and that is the important pressure for us by which we measure it. So if the pain producing pressure is less than 15, 0 to 15, then it is known as the mechanically sensitive disc. It is between 15 to 50, it is known as the it is between 0 to 15, it is the chemically sensitive disc. 15 to 50 is the mechanically sensitive disc, and more than 50, 50 to 90 is the indeterminate, and more than 90 usually do not go. So that is the thing, and these are all in PSI, that is the pascals per square inch. And this is the picture of the post-discogram CT scan. With the post-discogram CT scan, we can find out which type of discogram we are seeing. So when it is only inside the nucleus pulposus, it is known as the grade 0, or that's absolutely normal disc. Grade 1 going to the inner third of the annulus and also remaining within the nucleus, that is the grade 1. Grade 2 goes middle third of the annulus, and grade 3 goes outer third of the annulus, and grade 4 usually there is a annular fissure along with the radial fissure, and in the grade 5 it comes outside. So the grade 5 is basically an extruded disc. So these are the gradations of the disc degeneration, and here in this picture you can see it's a grade 1 disc, and here you can grade 0 disc are not involved in grade 1, and here you can see the grade 4 disc. Okay, so here as a along with the radial fissure we can see an annular fissure. So that is the grade 4 type of disc. So by which we can find out usually grade 1 and grade 2 mostly remains asymptomatic, whereas the grade 3 and grade 4 actually the source of the pain. So this is a way to find out. Let's come to the selective nerve root block. In MRI, you might have seen there are multiple times in patients there are discs, and these disc bulges may or may not cause pain. Sometimes it becomes very difficult to find out which disc is the source of the pain, for which we perform the selective nerve root block, in which the technique is similar with the transforaminal epidural steroid injection. We take the needle close to the nerve root from the lateral side, and then we inject small amount, 0.5 ml of the local anesthetic in the nerve root, and we check whether that is pain relief or not. So if the pain is relieved, then we can find out that this root is the source of the pain, and we can direct our treatment accordingly. So there are technically difference between the SNRB and TFESI. The procedure wise both are the same. That means we are putting the needle at the same point, but SNRB is purely a diagnostic procedure, whereas the transforaminal epidural steroid injection we give more volume so that the volume goes inside the epidural space, and it can be having more therapeutic effect. Okay, but the procedure wise they are not much different. Now for the selective nerve root block, when it is in the pure sense, we do not use the steroid, and whereas in the transforaminal epidural steroid injection we always use the steroid. So the main is the motive. For the SNRB, the motive is the diagnosis and finding the pain generator, whereas for the transforaminal epidural steroid injection, the motive is to reduce the pain and inflammation on the nerve root, and ultimately giving a medium to long-term pain relief. Epidurogram is the imaging technique to visualize the epidural space by using the contrast dye within the epidural space. And here the purpose is to assess the anatomy and identify the adhesions or herniated discs may be present. And procedure is done under fluoroscopy, and where usually in most of the cases to the caudal epidural space we go up to the S2, and then we inject the dye within this, and ultimately we get an inverted factory appearance. We check for any localized filling defect, especially in settings of the post operation, that means the post laminectomy cases, and where if there is a filling defect in one side or one area, that could be a chance of adhesion, and that can give rise to pain as well. So what are the important things to read the epidurogram? First, look and identify the epidural space and find the outline filled by the contrast medium. ensure the distribution. Remember, there are three patterns. Usually, in case of epidural dye spread, it should always come through the foramens, as well as there will be patchy distribution. Patchy, why is this patchy? Because the reason behind is that there are epidural fats. It's not a homogeneous space, so it will be a patchy distribution. It should be coming out through the foramen. So we have to find out these characters of the epidural spread, and then we have to find out whether in any specific space, especially in the case of surgery close to the surgical area, whether there is adequate filling or not. If there is not adequate filling, usually we can go with a catheter and we can clear with the saline, as well as then we can give the contrast and check whether these additions are removed or not. So the check for abnormalities like the additions, herniated disc, or any unusual masses or contour changes that is obscuring the dye. So that means the epidurogram, we can find out this epidural fluid flow is normal or not. The one step ahead of the epidurography is basically the spinal epiduroscopy, which is a flexible epiduroscope which is passed through the caudal epidural space, and we can check the epidural additions as well. But remember, though it came with a big promise, the spinal epiduroscopy or spinal endoscopy, but ultimately it was not much beneficial, because what happens even we find out an addition or a mass, ultimately you have to go for surgery, because here, in those cases, mostly you cannot do much maneuver with the epiduroscope only. In case of additions, if it is mild or moderate, that we can remove with the tip of the epiduroscope. But for all the other type of procedures, either you have to go for the rigid endoscope or we have to go for the surgery. So that is the big drawback for the fiber optic endoscopy. So though it came with a big promise, but ultimately it could not deliver that much potential, because for the diagnostic tool it is good, but for the doing the things or doing the procedure, it is not that great. So it is nowadays not a very popular thing. Next, coming to the sympathetic blocks, it is also very important to have the sympathetic block. So it is basically the injection of the anesthetic into the lumbar sympathetic chain to relieve the pain. Purpose is to find out whether the pain is because of the complex regional pain syndrome or because of some vasospastic or vaso-occlusive disease. So, for example, I have told you the frostbite, Reynolds disease, sometimes in case of Buerger's disease, this situation can happen where there is pain because of the occlusion of the vessels, maybe partial, and sometimes here we just inject and we find out that the flow in the blood flow in the limb will be increased with the sympathetic blockage. And then also we can find out sometimes, like I've already told, in a number of cases, not only by me, but a number of pain physicians, what we have done by limb multiple injections, ultimately even they reduce the gangrene, or they will, if it is possible, save limb as well. So it provides pain relief and serves as a diagnostic tool as well as a therapeutic tool as well. So that is the importance of the sympathetic nerve root block. In the lumbar area, usually we go for the lumbar sympathetic nerve root block, and lumbar sympathetic chain remains at the anterolateral corner of the vertebral body. There are some positions that the level of the L2, L3, and L4 that will come to the details. So here with the technique, we have to go to the anterolateral corner and then we have to inject the drug. Mainly the neurolytic here is preferred. Also, we can do the radiofrequency ablation, but for which we need the multiple needle placement, and ultimately we can give a long-term pain relief with the radiofrequency ablation. Similarly, we have the sacroiliac joint block that I have discussed previously as well within this lecture, that when we are suspecting the sacroiliac joint is the source of the pain, it could be due to different causes. Sometimes it could be inflammatory because of the inflammatory arthropathies, or sometimes it could be possibly a degenerative change, or sometimes it can happen in the young age also. Some patients might have an injury in one leg, ultimately the patient is limping, so there is an unequal distribution of the weight load in the sacroiliac joints, and ultimately that can also give rise to a sacroiliitis. So basically it is not that in old aged patient the regenerative sacroiliitis will occur, though it's more common in the old age, but in young patients also, because of certain situations of the leg, or sometimes there could be a congenital limb length discrepancy, or sometimes an acquired, for example, there could be a leg injury and then surgery is done. Ultimately, one limb length shortening is there, and ultimately that is causing the pain. So there are multiple causes for which the sacroiliitis might happen, and in those conditions, we can actually go for the diagnostic sacroiliac joint block to block the sacroiliac joint, and actually our aim is to give to the pain relief for the patient and also diagnose it. And ultimately, after diagnosis, we can go for the therapeutic options like radiofrequency ablation, cryoablation, or sometimes we can go for the cool radiofrequency ablation. But remember, though there are multiple types of radiofrequency ablations or heat ablation, cold ablation, everything is available for the sacroiliac joint. But always remember that the most evidence-based is one is the intra-articular injection of the steroid into the sacroiliac joint, and that we can do commonly, because there is a drawback for the ablations, because the sacroiliac joint nerve supply is very diverse. It is not coming from one place. It is actually coming from multiple places. So sometimes even with the best techniques, even with the best thing, we are not able to totally block the sacroiliac joint. So even though we cannot do that, so ultimately it has been found that evidence says that the evidence for the intra-articular injection for the sacroiliac joint is comparatively higher than doing the radiofrequency ablation. Though for the chronic cases, we have to actually go for the radiofrequency ablation, but initially we go 2-3 sets of the diagnostic or intra-articular injections, therapeutic, and then we have to go for the ablations. So this is the sacroiliac joint injection. Here technique is slightly different than from other lumbar procedures, because in all other lumbar procedures, mostly we go from the ipsilateral side for the injection, but sacroiliac joint, the angulation is such, we have to come from the opposite side. And ultimately, we have to go inside the sacroiliac joint, we have to give dye, get an arthrogram, and we confirm the needle is within the joint, then we inject the local anesthetic and steroid. And remember, the inside volume is very low, ultimately 2 cc of the steroid, that maximum 3 cc that you can give. And ultimately, you have to come out with the needle. So if there is pain, definitely the mixture of the steroid local anesthetic will give a local initial pain relief because of the local anesthetic, and also in long term because of the steroid you will get a good pain relief, and sometimes the procedure need to be repeated. But it is a very rewarding procedure and the results are quite good. Let's come to the trigger point injection. The normal muscles are not pain generator and they are not pain sensitive structures within it. But what happens when the muscle is also degenerated? So in case of muscles, sometimes there is a condition which is known as the trigger point formation. So you might ask, what are the cause for such a generation of a pain generator within a muscle? So it is a big thing. Basically, if you read, there are multiple hypotheses for that. Some says there could be possible initial trauma and calcium release which causes the vasoconstriction. Ultimately, it gives rise to a painful tendon node within the muscle. Some says there is a energy crisis theory. So there is a not adequate high power ATP, rather there is some ADP formation, and because of the lack of energy within the muscle, adequate supply is not there, and ultimately that develops a myofascial trigger point. Some says around the motor end plate, known as the end plate theory, there is a local circuit formation that causes continuous contraction of the muscle, and ultimately that forms the trigger point. But whatever the reason is, actually what happens within the muscle, there is a point or node-like situation that is causing the pain. Sometimes this pain is localized, sometimes it can be referred to the different areas as well. Sometimes it can mimic even a radiculopathy, though in the classic sense, but radiculopathy is not also always the classic. So sometimes it can mimic other conditions also, and for which the simple technique is that go inside the joint whenever, sorry, not the joint, inside the tendon node, basically the muscular nodule, and when we are going, usually the muscle can get a contraction that is known as a jump sign, and after that you inject small amount of local anesthetic, and then you ask the patient whether the pain is gone or not. And in a number of situations, it can give a dramatic result. You might have seen there is a radicular pain coming and going to the legs, or it's a cervical radicular pain coming to the hands, and ultimately you done the trigger point injection and you find a very good pain relief. This is a very common phenomenon. And sometimes another thing might happen, that both the condition might coexist. Because of the pain, there is lack of movement, and because of the lack of the movement, lack of supply of the blood, ultimately within that muscle there is a formation of trigger point. So it is not absolute that every time it will be the isolated as a trigger point, but it can present with the other pathologies as well. So even for that, when we are doing a facet injection or a radicular or nerve root injection, sometimes there might be happen that when we are going within the muscle of the erector spine, that there are trigger point and nodules within the erector spine, then we have to do the trigger point injection then and then, so that we can relieve that pain. And sometimes you might have find that after doing that, the pain relief is such you don't need to go inside actually. So this happens in a number of cases. So remember, trigger point is an important source of pain. It is very easy to treat. Sometimes you need recurrent injection, but ultimately diagnosis and treatment is very simple in those conditions. So just go and try to do that. And if it is responding well, it's a very good thing, and for you and for the patient as well. So that was all about in a nutshell, the diagnostic interventions that we do for the back pain, but definitely in the next classes, we'll go in more detail and we'll be discussing each and every causes separately. Any questions? Irmada, have you opened the quiz.com?
But I have only 5. Today only 5 questions. So
Okay, everyone, please join the quiz.com. So if you have any questions, you please ask in the beginning of the next class or today also. But don't remain silent, because then it is very difficult to understand for us whether you are able to understand or not. And these basics are very important.
Nanometer. Bouncy Unlucky wasp. Snail. Cool fire. A. Dr. Captain Slow Space. Meg Foolish Slow. Uncle Slow. Sister Lion. A beta Love student. Mama Queen.
okay, I'm starting.
Haunted pig.
Just open quiz.com and this pin you can put 59872 Okay, I'm starting. Others can join. Only 5 questions.
Quiz.com. Play and create.
What you are not seen here. Equal pedicle spinous process distance at L4. What is this marked structure?
Lena Reader joined.
Pedicle. Which structure will be hit if a needle is placed here through the back? Nose of the Scotty dog. What is incorrect about the area marked under the arrow? Most of the right-sided back pain interventions are done in this view.
Left side.
Final question. Double points.
What is not important in a diagnostic block? MRI abnormality.
It is not must.
Third place. A beta fiber. Second place. Love student. And the winner is Bouncy Wasp.
So, okay. Who is Bouncy Wops?
Yeah, sir.
Okay, congratulations.
Thank you, sir.
For today, this much only. We will meet next day. If you have any question, please ask me. And you see the recordings multiple times to understand the concept clearly. Okay. Thank you. Good night.
Thank you.